So I will revise the kidney structure a little bit at the beginning. Then I'll try to list main compartments within the kidney, discuss mechanisms of injury, so how this kidney can get affected. Sorry about that. And discuss investigations used in renal diseases, discuss clinical presentation patterns of renal disease, and discuss pathophysiological correlations of each pattern of clinical presentation. So to start off with, you know the normal functions of the kidney. So the kidneys are very important in waste excretion, water regulation, electrolyte regulation like sodium, potassium, calcium. It's very, very important in the management of acid-base balance. Endocrine, it functions as an endocrine organ where it produces erythropoietin, renin, vitamin D. The active form is converted to the active form in the kidneys. It's one of the main organs controlling hemodynamic regulation, and it's a central organ governing mineral bone regulation as well. So just to very quickly go through the structure, you are very familiar with this. You have two kidneys which are retroperitoneally situated in your body. And if you take a longitudinal section of this, you have the outer cortex, which is this, and then the inner medulla, which drains into through the major and minor calyxes into the renal pelvis and urine is going out through the ureters. And you have the renal artery and the renal vein, that is the blood supply of the kidneys. If you go in deeper into this, you will see that when the artery and the vein comes into the kidney, it branches out into your arterioles and the very small small arteries. And then when you plug in further, you go into this functional compartment of the kidney called the nephron, which is constituting of your glomerulus, and then the tubules, and then you have the vasa recta and the blood vessels surrounding that. So this single unit is your functional unit of the kidney. So based on this, we mainly, which is clinically important for us, we try to divide this into 4 main compartments. That is your glomeruli, tubules, interstitium, and blood vessels. Each of these compartments can separately or together be affected with different disease processes. However, clinically it can manifest differently depending on where it has been affected. So for discussion purpose, I'll try to first take each compartment separately and we'll go through one by one. So this is your glomerulus. You have the afferent arteriole coming and branching out into glomerular capillaries, and then efferent arteriole going out. And if you can remember the anatomy of the nephron, you can have a loop of the tubules coming back up and forming the juxtaglomerular apparatus here in this part. And if you look it under a scanning electrode microscope from the outside, this is what your glomerulus is going to look like. So you have lots and lots of glomerular capillaries like this, which are in a ball-like thing within the kidney. If you go further in with an electron microscope, so this is your glomerular capillary, and this is looking from outside of that. This is your podocytes. And you can see nicely that they are interdigitating, fingered like foot processes, which you have learned for your anatomy and histology during your anatomy days. So if you take a cross section, now this is a picture I want you all to learn and get into your head today and to keep it for the rest of your life, because if you understand the structure very well, it's very easier to understand the disease processes and the clinical manifestations. So if you take a cross section of the glomerulus, this is what it's going to look like. So here you have your glomerular capillaries, and as you can see, they are fenestrated. So you have small fenestrations in the glomerular capillary endothelium. And surrounding that, like in anywhere in the body, you have a glomerular basement membrane that is going all around like this, around your capillaries. And very interesting, if you notice, this glomerular basement membrane doesn't go fully around the capillary wall. It's only covering part and then going to the other, so that you can see this part is actually more or less open to the middle. And around that glomerular basement membrane, you have these fingered foot processors. And on the medial side of it, you have the mesangial cells, which holds together all these glomerular capillaries. And you can understand, because there is no glomerular basement membrane here, any disease process that happens within these capillaries and the inflammatory cells and everything can very easily go into the mesangium. So they are actually in a way connected. Then outside this foot processors, you have this space around that, and that is called your urinary space. And that is where the urine gets goes into the glomerulus. And around that, you have what is called the parietal epithelial cell. So the podocyte, you call it the visceral parietal cells, visceral epithelial cells. And the cells that are on the outer covering, you call it the parietal epithelial cells. And if you look under this glomerulus under a microscope, and this picture I'm sure you have seen by now in your pathology, this is a glomerulus, and these open loop whitish areas with a nice surrounding, these are your capillaries. And in between you see these cells, these are your mesangial cells, that are these cells that are actually holding these capillaries together. And on the outer edge here, you see these whitish areas, that is your urinary space, that is this space around the glomerulus. And in the surrounding, you have your tubules. So you can see nicely packed tubules on the surrounding. If you look at the fenestrated endothelium from inside through an electron microscopy, this is what the inside will look like. There will be small holes which are called fenestrations in the endothelium of these glomerular capillary walls. And you can imagine small particles, small things going through these to the outer urinary space. So that structure you really need to understand well in order to understand what can happen abnormally in the kidney. Now, first we'll talk about the glomerular basement membrane and the podocyte. So now here we've gone through this picture. If you enlarge this area, you have the podocyte, and in between podocyte there is this small space called slit diaphragm, and there are multiple molecules bridging these slit diaphragms. And on the other side, you have the endothelium and the endothelial cell. In between these podocyte and the endothelial cell, you have the glomerular basement membrane. If you go in further, enlarge it, zoom in further with the electron microscopy, these are your podocytes, the foot processors. This is your glomerular basement membrane. This is your endothelium, and you can see these small spaces in between these foot processors, which are called your slit diaphragm. If you enlarge it further, now this is your foot process, this slit diaphragm, in between these slit diaphragms, there are multiple molecules, protein molecules, which bridge these slit diaphragms. And that is when, if these are abnormal, that is when you start developing protein leak and abnormal molecules start going through the glomerulus into the urine. So most of those things we will discuss further later in the presentation. So what does the glomerular basement membrane do? It has a very strong negative charge, and you can understand. Because of that, depending on the charge, depending on the size of the molecules, what goes through this glomerular basement membrane will vary. For example, if you have big molecules, it's going to be very difficult to go through this glomerular basement membrane. If you have negatively charged molecules such as albumin, it's again going to be very difficult because already it is negatively charged and it's going to repel. So whatever that's going to damage the glomerular basement membrane is going to damage this negative charge, and that's when even molecules like albumin can go through the glomerulus. So how does the glomerular structure get damaged? So there are many mechanisms how the glomerulus can get damaged. So these are some of the common ways. One of that is your antibody mediated injury. So that is, for some reason, if you develop abnormal antibodies in the body, it can directly go and damage the glomerular structure and cause damage. You sometimes can get immune complexes forming. The immune complexes can form in situ. In situ means within the circulation you can get immune complexes developing. Sometimes these immune complexes directly go and deposit in the glomerulus and the glomerular basement membrane, causing damage. And the other way is that through activation of the alternate complement pathway. So whether it's an antibody or whether it's an immune complex, when it goes and deposits in the glomerular, sometimes it activates this alternate complement pathway. So for example, conditions like hemolytic uremic syndrome, which you will learn later, is one of those conditions where the alternate complement pathway is activated. The other condition way is non-immune mediated, so there is no immune mechanism, but it could be secondary to metabolic conditions like diabetes, it could be renovascular diseases like hypertension, deposition diseases, inherited conditions like due to their genetic abnormalities, or infections which can directly affect the glomerulus and cause damage. So when we talk about immune complexes, these immune complexes can go and deposit at any place within the glomerulus. But depending on where they get deposit, the clinical manifestations can vary. So for example, this picture, so you need to orient yourself there. This is your podocyte, this is your glomerular basement membrane, and this is your endothelium and the mesangial cell. So this side is that. So here you can see these are your immune complexes. So you have an antibody and an antigen that has gotten formed, and you can see that it's depositing in the subendothelial space. Subendothelial space means this is the endothelium, and you have the glomerular basement membrane. It's depositing between those. Those are called subendothelial immune deposits. As opposed to that, here you can see the immune complexes are deposited in the glomerular basement membrane within that. And here you can see here the immune complexes have gone past the glomerular basement membrane and depositing between the glomerular basement membrane and the podocyte here. These are called subepithelial deposits. So I'll show you in a different picture. So here again, orient yourself. This is your podocyte, glomerular basement membrane, and the endothelium of the capillary. So if you have deposits here between the endothelium and the glomerular basement membrane, you call them subendothelial deposits. If they deposit outside the glomerular basement membrane on this side, you call them subepithelial deposits. Sometimes these deposits can deposit within the mesangium. Then you call them mesangial deposits. So you will understand the importance of this later during the course of today's talk. So whenever there is injury with any of those mechanisms that I mentioned, the glomerulus will start reacting to it. So just like anywhere else in the body, there is an immune response, a host response to the injury. And as a result, sometimes these are some of the manifestations that will come about. You can get hypercellularity, meaning you can get a lot of cells getting proliferation, a lot of mesangial and endothelial cells getting proliferated. Sometimes because of this injury, a lot of neutrophils, lymphocytes will start coming into the place. And if the damage happens, sometimes you get what is called crescent formation. That is, this parietal epithelial cell starts proliferating. So then you get what is called a crescent, which we will talk about later. So all those are some of the responses to injury. Sometimes you get basement membrane thickening. So here you have the glomerular basement membrane. For example, when those immune complexes go and get deposited within the glomerular basement membrane, you will start seeing it getting thicker and thicker because of these immune complexes. And sometimes you get what is called hyalinosis and sclerosis, where you get accumulation of eosinophils and homogeneous material, and this can actually obstruct the glomerular capillary lumen. And therefore you can see this is going to either aggravate the injury to the glomerulus and also going to result in long-term sequelae to the kidney. So with glomerular injury, how does this manifest clinically? So now, mind you, we are talking about the glomerular structure only at the moment. That is the glomerulus, the basement membrane, the food process, that structure. So when there is the injury there, how do these clinically manifest? So the easier way to remember this is, one way that is very easy to remember is that you divide it into where these immune complexes damage. So for example, if it's the podocyte that gets damaged, so here you can see this is a normal glomerulus. You have the podocytes nicely, the food processes, your glomerular basement membrane endothelial cell. And if the food process is affected, for example, like in minimal change and FSGS, I'm sure you have been taught this by now, where the podocytes are damaged, there you can understand that the slit diaphragms, those molecules that I showed you before, all are going to get damaged, and proteins going to easily leak through these places. And then you end up with significant proteinuria, where the patient will start complaining of frothy urine and edema, because the albumin levels are low, and these patients can become very edematous. As opposed to that, if the damage is happening on the inner side of the glomerular basement membrane, so here when it's podocytes, it's on the outer side. If it's happening within the glomerular basement membrane, on this side, on the endothelial side, there you get what is called proliferative lesions. So with this damage, there is a lot of neutrophils, a lot of inflammatory cells coming. They will damage the endothelial cell, and then within whatever that is within the blood vessels will start leaking through the kidney. So for example, you will start getting hematuria because the red cells will go out of the circulation. Protein will go out of the circulation. And you can understand, with a lot of cells within these capillaries, the glomerular filtration is also going to go down. So clinically, this will manifest as hematuria, proteinuria, reduced urine output. And a classic example of this is your post-streptococcal glomerular nephritis. Right. So moving on to tubules. Now we discussed what will happen if the glomerulus gets affected. If the disease, now we move on to tubules. And if you can remember, so once we come out of the glomerulus, you have your tubules, the proximal tubules, the loop of Henle, the distal convoluted tubules, the collecting ducts. All these are the tubular structures. And on a biopsy, this is how you are going to see your tubules. So you can see tubules very nicely compacted, hardly any interstitial structures within these tubules. They'll be very, very nicely compacted. This is the tubular endothelium, and you can see the tubular lumen pattern. So how can these tubules get damaged? So mainly the tubules can get damaged because of ischemia, for example, hypotension, or any cause that's going to cause reduced blood flow to the kidney will cause ischemic tubular damage. The other way the tubules can get damaged is through direct toxicity. For example, nephrotoxics like heavy metals and NSAIDs. Hemoglobinuria, if you have severe acute hemolysis due to, example, G6PD deficiency or any condition like that, that hemoglobin directly going and can go and damage the tubules. And for example, in rhabdomyolysis, the myoglobulins can go and damage the tubules. So those are some of the causes of direct tubular damage. And then there are causes where it affects the tubules as well as your interstitium. For example, in infections, some of the metabolic conditions like hypercalcemia can cause tubular interstitial nephritis. So these are some of the mechanisms by which tubules are damaged. So what happens when your tubules are damaged? So if you look at this picture, you can see this is your glomerulus, and then you have fluid urine going into the tubules, and that is lined by your tubular cells. Whenever you have tubular damage through ischemia or direct toxic injury, your tubules get damaged, and those tubules that are damaged will get sloughed into the tubular lumen. And once it gets sloughed, you can imagine, one, it's going to cause obstruction within the tubules, so that's going to cause reduced kidney GFR. At the same time, these tubules do a lot of functions in the kidney. your water absorption, your electrolyte management, acid-base management, all of those things are done by the tubules. So all of those functions are going to get affected, and you start developing electrolyte abnormalities, acid-base problems, things like that. So that is how tubular damage can manifest clinically in a person with respect to, it could be GFR becoming low, it could be electrolyte abnormalities, it could be acid-base balances. So clinically, like I mentioned, it can manifest like what I just mentioned in any of these mechanisms. Right. So that is the tubules. Now we'll go just outside the tubules, the interstitium. And if you remember the picture very well, the tubules are always surrounded by a good interstitial compartment. So there are conditions which can affect this interstitium directly. So you can divide it into non-infective causes and infective causes, where your non-infective causes are mainly related to drugs, like some of the antibiotics, analgesics. There are metabolic conditions like hypercalcemia, autoimmune conditions like SLE can affect the interstitium. And then you have your infective causes like pyelonephritis, which can cause direct interstitial damage. And if you can remember the picture I mentioned, your tubules and the interstitiums are very close to each other. So most of the time, if any condition affects the tubules, that's going to affect the interstitium as well, and vice versa. Where if the interstitium is affected, it's going to affect the tubules as well. So you generally call it tubulo-interstitial diseases, because most of the these conditions coexist together. So this is a picture on your left hand side. This is a normal appearance of how you would see the tubules on a renal biopsy. You have your tubules, tubular lumen, nicely patent, and very minimum interstitium within the tubules. However, if you look at the picture on the right side, you can see now these are your tubules, and they are very widely placed now. They are not compacted, and in between these tubules, you can see these black dots. And that is your acute inflammatory cells, your neutrophils. So here you've got an element of acute interstitial nephritis, which you can see with conditions such as pyelonephritis or any infection. So when this interstitium is affected, how does this clinically manifest? So if it's acute, you can understand that will reduce your kidney function, because the interstitium and the tubules are very, very important to maintain normal kidney function. You can get proteinuria, sometimes a little bit of hematuria, and patients, depending on the underlying etiology, if it's secondary to a drug, patient might develop fever, eosinophilia, and joint pains. And then there are conditions where this happens over a period of time. And if that is the case, you call it chronic interstitial nephritis, where your kidney function decline will be gradual compared to acute interstitial nephritis. When you do a urine sample, you'll have some proteinuria there. And sometimes, depending on where in the interstitium is affected, you will have tubular damage and tubular dysfunction as well. So that is how tubular and interstitial damage is going to manifest clinically. Now we'll go to the next compartment, which is our blood vessels. So in the blood vessels, one of the first things to know is that the kidney receives 25% of your cardiac output. And of this cardiac output, most of the blood is seen in the cortex, because that is where you have the most activity in the kidneys, because your glomerulus and all of that is predominantly situated in your cortex, and you have the highest oxygen requirement there. The other important thing is your cortical arteries are end arteries. So you can imagine if you damage one of these arteries, there is no collateral to supply blood from another place. So that damage becomes very permanent. Therefore, chronic vascular diseases will affect the kidney. The other important thing is the efferent arteriole supplies the peritubular vessels and the vasa recta. And if you remember the picture, anything that's going to cause tubular glomerular damage, then your efferent arterial blood supply is going to go down, because The efferent arteriole is situated after your glomerulus. So whatever that is downstream after the glomerulus is going to get affected. So this is what I'm saying. So you have your kidney, you have your renal artery, and it branches out into the small branches. And then finally, through the interlobular artery, you get the afferent arteriole, the glomerulus, and the efferent arteriole, and then the vasa recta. So if there is any damage here, and you can imagine downstream, the blood supply is also going to get affected. And if the blood supply gets affected, you can imagine all these structures, the tubules and everything that is supplied by this blood supply are going to get affected. And then you will start developing other problems with the tubular interstitium as well. So you can see that all these units are all interlinked. If one gets affected, the other structure also gets affected. So how do these blood vessels within the kidney get affected? So there are many conditions that can affect this, but the commonly seen conditions are hypertension, renal artery stenosis, thromboembolic diseases where you start having thrombotic manifestations of the kidney, thrombotic microangiopathies, where I will talk a little bit later on thrombotic microangiopathies, vasculitis, where there's inflammation of the blood vessels, and pre-renal conditions, for example, like heart failure, shock, where the perfusion to the kidney is low, thereby reducing blood flow to the kidney, and that can lead to acute tubular necrosis. Therefore, as I mentioned before, all of these conditions can affect the kidney, blood supply, can affect the other compartments of the kidney as well, because these are all interlinked. Now, this is what I mean by thrombotic microangiopathy. So commonly known thrombotic microangiopathy conditions are, for example, your TTP, your thrombotic thrombocytopenic purpura, hemolytic uremic syndrome are two common conditions. And here the pathology is, you have the blood vessels, and within the blood vessel, whatever the cause could be an infection, it could be a toxin, those go and damage the endothelium of this blood vessels and the capillaries, thereby activating platelet aggregation and clotting within the blood vessels. So you call it thrombotic microangiopathy, and you can imagine when these blood vessels get blocked with these clots, the blood supply distal to that is going to get cut off. So all the tissues that are being perfused beyond that gets affected. So thrombotic microangiopathy commonly affects kidneys because the blood supply is so much and you have very small blood vessels within the kidney. It can very easily get affected. And clinically, this can manifest as reduced renal function or GFR, hematuria, and hypertension. So I need to again stress that even though I've spoken about these compartments separately, all these compartments are interdependent. The study of the kidney is easy by dividing it into 4 segments, but still they function as a single unit. Initial damage, what will, depending on which segment is affected, can manifest as different distinct clinical entities. For example, if it's the glomerulus, you might have proteinuria, hematuria. If it's the tubules, you might have electrolyte abnormalities, acid-base problems likewise. But later on, as these diseases progress, because these are interdependent, you will get manifestations of all. Right. So knowing these things are not adequate, we need to know a little bit about how to investigate to identify these abnormalities. So the main thing to look at is your kidney function. So the investigations to look at kidney function are your glomerular filtration rate. And you have learned this in your physiology days. You've learned that the normal glomerular filtration rate is somewhere around 120 to 130 milliliters per minute per 1.73 square meters. So the best way to measure this is if you do a 24-hour inulin clearance or a 24-hour creatinine clearance. However, even though you learn this in your physiology to do, This is a very cumbersome procedure and you need a lab setup to do this. So in clinical practice, in the ward, we can't be collecting urine for 24 hours in all patients to assess kidney function. So in this hospitals, in the practical setting, what we do is we do what is called a spot serum creatinine, and using that, we estimate the glomerular filtration rate in these patients. So I'm not going to talk about GFR today because I assume all of you know what GFR is. I'm going to straight away go to how we try to investigate this GFR in a clinical setting. So in the ward setting, we use creatinine to look at kidney function. So the basis of using creatinine is this. So you know that creatinine is a metabolite product of your muscle. And when we measure creatinine in the blood sample to have an indirect assessment of the kidney function. Why we do that is, at the glomerulus, creatinine is freely filtered and it goes out in the urine. In your physiology days, you would have been told that to be a good molecule to assess glomerular filtration rate, it has to be something that gets freely filtered from the glomerulus, but does not get reabsorbed or secreted at the tubules. Creatinine is freely filtered from the glomerulus, but unfortunately, there is about a 10% secretion from the tubules as well. So it's not a very accurate, 100% accurate marker, but this is the best marker we have got so far to use in a clinical setting in the ward setup. So when we measure creatinine, higher the creatinine value, that means less the amount of creatinine that is getting filtered in the kidney. So higher the creatinine, lower the kidney function. So now we have developed these equations. So one of that is called CKD-EPI, another one is MDRD. You don't have to know these equations, but know that there are these equations where if you know the creatinine value of a patient, if you know whether the patient is male or female, if you know the patient's age, you can directly put this into an equation and automatically we can calculate the GFR of a person. So that is called an estimated GFR. Thereby we can get a rough assessment of an individual's glomerular filtration rate. So that is how we check a person's renal function. So the drawbacks of using creatinine is, one, I told you that there is some degree of secretion that happens at the tubular level. The other problem is, if you look at this graph very carefully, on this axis you have creatinine that is gradually increasing, and on this axis you have GFR that is increasing on this direction. And you can see GFR has dropped more than 50% and still the creatinine hasn't risen very much. Creatinine starts rising only when your GFR has dropped more than 50% from its baseline. So you can see that creatinine is a delayed marker. It doesn't quickly go up when there's kidney damage. It has a bit of a lag time before it starts increasing. So it's again not an early mark of kidney problems, but that is one of the drawbacks. The other thing is it is dependent on muscle mass, diet, and your hydration status. So as I mentioned in the previous slide, your creatinine is produced as a metabolite from your muscle. So if you have more muscle, the higher your creatinine will be. And even in a muscular person, if you have a slightly higher creatinine, that doesn't mean that that person's kidney function is low, but that person has more muscle mass. Similarly, if you take a high protein diet, high meat containing diet, your creatinine can go up. If you are dehydrated and measure your serum creatinine, because of the concentrated blood, your creatinine can go up. So those will be confounders when you measure the creatinine value. So the next aspect we need to look at when we are investigating is assessing your urine. So here I'm going to only talk about proteinuria and red cells. So in proteinuria, you can see, now again going through the picture, you have your afferent arteriole, the glomerulus, efferent arteriole, tubules come and go out, and here you have the urine. So your proteins can come from your glomerulus, proteins, once it comes down, some of them gets reabsorbed at the tubular level. Some of them can get secreted from the tubules as well. And finally, you get a final amount of protein in the urine. So in a normal person, you can accept up to 150 milligrams of proteins for 24 hours. So it's not nil. Every one of us passes a little bit of protein in your urine, and up to 150 milligrams is acceptable per day. Now, within these proteins, you can have a little bit of albumin as well. Even though they are big molecules, a little bit of albumin can go in your urine. Up to 30 milligrams per day, you can accept albumin in your urine. So out of this 150, up to 30 can be acceptable. However, if it is more than this, then that is considered abnormal. So how can we get this abnormal protein? They can be because of glomerular problems, tubular problems, or what we call overload proteinuria. That is when the body is producing more and more protein abnormally. For example, in your multiple myeloma patients, you would have learned that they have abnormal plasma cell proliferations, abnormal amounts of myeloma proteins that are secreted, and that can overburden the kidney and get filtered in the urine. So that is called overload proteinuria. So these are mechanisms by which you can have protein in the urine. So this is again to show those. So when you talk about glomerular proteinuria, any damage to the glomerular barrier will cause proteinuria. So for example, your nephrotic syndrome, where your podocytes and the glomerular basement membranes are damaged, you can get proteinuria. And most of these times, albumin is one of the predominant proteins that gets leaked. If you talk about tubular damage, there you can get proteins getting secreted or minimum reabsorption at a tubular level, causing more proteinuria. However, there it's not albumin that's the predominant protein. You get other proteins like low molecular weight proteins like beta-2 microglobulins, alpha-1 microglobulins that are going to go in the urine. And overflow proteinuria, like I mentioned, is when you have abnormal amounts of protein produced by the body in the cases like in light chains and myelomas, where protein can go in the urine. The next aspect of urine to look at that is very important is your red cells, which you call hematuria. So normally when you have abnormal amount of red cells, we divide it into two types, glomerular hematuria or non-glomerular hematuria. So glomerular hematuria means when the bleeding is coming from the upper urinary tract, that is your glomerulus and the upper tubules, you call that glomerular hematuria. And if you are having non-glomerular hematuria, that means you are bleeding, your hematuria is coming from the lower urinary tract. For example, it could be the renal pelvis, ureters, or your bladder. So how do you differentiate these? If it's glomerular hematuria, you look at the urinary sediment under the microscope and you will see what is called dysmorphic red cells. So that is abnormally shaped red cells in your urine, and these are called dysmorphic red cells. And you will get red cell casts and proteinuria as well. However, in non-glomerular proteinuria, you won't have these dysmorphic red cells. The red cells will look normal. That is, your round, regular shaped red cells will be there. There won't be any red cell casts. The proteinuria will be minimal, but you might have blood clots because the bleeding is heavy and could be coming from lower down, but you will not have significant amount of dysmorphic red cells. So that is the main way you divide whether it's glomerular or non-glomerular hematuria. Then the other important thing about when you are investigating renal disease is renal biopsy. So especially when it comes to glomerular conditions, we want to do renal biopsies in most of these patients. So for example, this is how you would see a normal kidney biopsy. Glomerulus, you have the tubules on the surrounding. You can see the nicely opened up glomerular capillaries and the mesangial cells. So here, this is an abnormal glomerulus, and you can see there is sclerosis, which is patchy, affecting part of the kidney, which is called focus segmental glomerular sclerosis. So this is a condition that will end up in nephrotic syndrome, and proteinuria, and sometimes end-stage kidney disease. This is another abnormal kidney. So here you can see the glomerulus getting collapsed, and around that you can see this crescent-shaped cells, and this is called what you call a crescent-shaped glomerular nephritis. So here outside the glomerulus, remember I mentioned you have the parietal epithelium that is proliferating, and you have a lot of cells on the outside called crescent-shaped glomerular nephritis. Thereby you can diagnose these conditions. Right, so finally, depending on where it's affected in the kidneys, how it has affected the kidneys, the clinical presentation of patients will differ. And generally, when a patient presents to you, they don't come telling you that I have a glomerular problem, I have a tubular problem, I have interstitial problem. That's not how they are going to present. They are going to present with a clinical symptom, a clinical sign. So the first task for you is to first identify what their clinical presentation pattern is. So for example, these are some of the common clinical presentation patterns you will encounter. A patient could present with a clinical picture of CKD. A patient could present with a clinical picture of acute kidney injury, nephrotic syndrome, nephritic syndrome, rapidly progressive glomerular nephritis. It could be a mixed nephrotic-nephritic picture. It could be any of these. So your first task is, when a patient presents, do the basic investigations that I just discussed, your urine estimations, your renal functions, all of that, and identify what the clinical presentation pattern is. And after that, you need to work out which compartment in the kidney is affected, what could be the underlying cause for this clinical presentation. So I'm going to stop there, and at the next presentation, I will discuss about CKD, AKI, and some of these clinical presentations separately so that you would understand this better.